Welcome to the presentation for Nursing 150, Module 5. For this presentation, we will continue to discuss disorders of the lower GI tract. For this presentation, we'll talk briefly about hemorrhoids, we'll discuss diverticular disease, and intestinal obstruction. First, we'll just briefly discuss hemorrhoids. Hemorrhoids are essentially varicose veins in the anorectal region. These veins develop there's veins there as a normal structure of the body, but at times they can get swollen and distended. They can be internal or external, and here's a picture here. It shows you here's the internal ones, here's the external hemorrhoids. Hemorrhoids can become extremely inflamed. They can cause bleeding, and at times can alert a person that they'll see blood, and it'll scare them a little bit, and that's why it requires further investigation. And at times we'll just find that it's a bleeding hemorrhoid. Increased intra-abdominal abdominal pressure is the main cause, and basically it's the pressure. Maybe a large stomach. For example, pregnancy can cause hemorrhoids, and that's because of the pressure of all that weight when a patient is sitting. Even standing, that causes pressure on the anorectal area. So basically that pressure extends these and distends these veins. And straining is also a big cause of this. The straining, like from chronic constipation, can cause the distended veins as well. Strenuous exercise and weightlifting, again, it's the pressure that's put on those veins. Prevention for hemorrhoids typically requires an increase in the fiber in the diet, increased fluid intake. All of that is to prevent constipation, which can cause pressure. Raw fruits and vegetables and whole grains are encouraged to prevent constipation. Plenty of quality fluids. Remind patient to avoid straining. And that's hopefully will be prevented by changing their diet a little bit and maintaining healthy weight. For pregnant people, there's not much we can do except for wait till the baby is born, and hopefully they'll be relieved of their symptoms of their hemorrhoids. Hemorrhoids are typically pretty harmless until they begin to bleed, and if they can get excessively bulging, excessively large, and sometimes they do have to have those removed if they get terribly enlarged. They are very painful and uncomfortable. Prevention and treatment is typically aimed at changing that diet, changing their lifestyle. And there are some just topical medications that can be applied to relieve the patient from pain. Some patients, like I said, do have to undergo surgical treatment. Post-op surgery for them is just pain management. Monitoring the site for bleeding and infection, and then making sure that they are able to have a bowel movement post-surgery, because it's going to be a little bit painful at first. Okay, diverticular disease. Diverticula essentially are these pouch-like herniations that occur through the muscular wall of the colon. Diverticulosis, the term diverticulosis is referring to the presence of these pouch-like herniations in the wall of the intestine. Acute diverticulitis means that those diverticuli have now become inflamed. So it's an inflammation of the diverticula. So make sure you're familiar with these terms and the differentiation between them. Diverticula is the presence of them. Diverticula is essentially just referring to those pouch-like herniations. Diverticulosis is the presence of them in the colon. Diverticulitis is an inflammation of these diverticula. So basically the important thing to understand is that some patients might have diverticulosis. That means they have the presence of those pouches along their large intestine. However, it may never become inflamed and may never cause them problems. Some people may never know they have them. It's when they become inflamed that they will become aware that they have them, because these can actually, these inflamed diverticula can cause some serious problems in the patient. It's kind of like appendicitis. Your appendix kind of accumulates debris in there. and causes an inflamed situation. The diverticula can also have this happen, basically retains undigested food in those pouches, and that can lead to a bacteria invasion and an inflamed diverticula, which can cause some pain and discomfort. And essentially, if it gets too inflamed, it can burst and cause an obstruction. It can cause a peritonitis. Varying degrees of diverticular disease. Diverticular often diagnosed maybe like on a screening colonoscopy, unless of course the patient has an episode where they become inflamed. Patient with diverticulitis has abdominal pain. They have left lower quadrant pain typically, becomes progressive and steady. They may develop signs and symptoms of peritonitis, which is nausea and vomiting, that a generalized abdominal pain, an elevated temperature, fever, chills, an increased heart rate can indicate that they have progressed to a peritonitis. Sometimes they'll have, especially in an older adult, they might have confusion as the signs and symptoms of peritonitis. Nursing focus for a patient who has diverticulitis. So this is an inflammation of the diverticula. Antibiotics are given usually for the inflammation. Pain medicine. They're not going to get any laxatives or enemas while they're having an inflamed episode. And that's because we don't want to aggravate the area while they're having an inflamed episode. They're going to rest and avoid activities that may increase intra-abdominal pressure. They're going to be provided a low-fiber diet during the inflammation stage. Older patients may not have pain, but we're going to carefully monitor them for signs and symptoms of pain, monitor for any mental status changes. We're going to perform frequent abdominal assessments, make sure that they're not moving on to a peritonitis. And then we're going to check for bleeding, any kind of bleeding in their stool. IV fluids might be required to increase their hydration and meet their nutritional needs and electrolyte needs. It's important to remember patients who have diverticular disease, the treatment for prevention of diverticulitis is different than the treatment for diverticulitis. Hopefully that makes sense. So the prevention, so people who have these diverticuli in their colon, preventing that from becoming diverticulitis is a little bit different than the treatment when they have diverticulitis. And we'll talk about that on the next slide. This is just a picture of the diverticuli, what they look like. So this is the presence of diverticuli. They're not inflamed here. So essentially, if somebody has these pouches, to prevent them from becoming inflamed, they need to increase their fluid intake. They need to prevent constipation. Because basically what happens is the flow of stool through here, the slower it is, as with constipation, the more likely that these pouches will get blockage, the more likely that things will get packed in there if they have constipation. So they need to increase fluid in their diet, increase fluid intake, increase fiber so that they prevent any kind of constipation. The other thing that they need to do is avoid foods that contain seeds or other indigestible material. Any seeds, especially like nuts, popcorn, tomatoes, strawberries, those are more likely to get stuck. Those seed-like undigestible things such as corn will get stuck in there, and that can increase the likelihood that these diverticula will get inflamed and collect all that undigested food, and they'll get bacteria growing in there and get inflamed, which can cause, as you can see, if these pouches get inflamed, it can obstruct the bowel. It can cause so much inflammation that it'll obstruct or it'll burst and cause a very serious condition in your patient. Now, in the presence that the patient does have a diverticulitis, so that's an inflamed condition, we will decrease the amount of fiber just because we do want to just chill things out a little bit. We don't want to give them an enema. We don't want to give them a laxative. That causes increased stimulation to the bowel, which actually we want it to rest. We want to give them the antibiotics so that the area can heal. Once that inflammation has gone down from the treatment of the antibiotics, then we can return the PO intake of fiber and everything to prevent it from happening again. Okay, we're going to talk about intestinal obstruction. Intestinal obstruction, just to kind of get an overview of an understanding of an intestinal obstruction. Remember, we talked about the GI system is meant for the food that we put into our mouth to flow forward through the GI system. And as it flows through, we pull out what we need from it, we absorb what we need, and then whatever we don't need passes on through. And it's meant to be one way through. Peristalsis aids in that movement through. An obstruction means that somewhere along the way something is obstructing that movement of the food and digestive particles through. That can create a very uncomfortable problem for the patient because we know that the body is going to try to keep pushing things through. But if it gets stuck in there, it can cause a pretty significant problem. It can have a complete obstruction, a partial obstruction, and they're also classified as a mechanical obstruction or a non-mechanical obstruction. Mechanical obstruction occurs when the bowel is physically blocked from problems outside of the intestine. Adhesions are basically scar tissue in the bowel wall, and then Crohn's disease can cause such an inflammation that it can create obstruction of flow through. The non-mechanical obstruction, also known as an ileus, and that's basically is a peristalsis problem. So basically, the patient might have some kind of a neuromuscular disturbance. Sometimes it can be related to opioid use, or sometimes just age creates the point where the peristalsis no longer moves the food along. So that's a non-mechanical obstruction. This is a picture of a couple of different types of obstruction. Intussusception can happen when the bowel kind of folds up onto itself. And then this is a volvulus twisting of the bowel, which can happen as well due to, sometimes it's just low fluid intake. Sometimes it's just the way we were born. I know intussusception can happen in newborns at times. These things can also happen post-operatively due to the decrease in peristalsis in the surgery. Of course, the problems that are going to arise from a bowel obstruction is poor elimination. It's going to be an elimination problem. It's going to be an absorption problem. It's going to be a nutrition problem because now that we don't have anything moving through, they're not going to be able to absorb. Basically, what happens initially when an obstruction starts is the body will try to compensate, and it will try to increase peristalsis to try to move everything through. The parts of the bowel that are working and still able to do peristalsis will start increasing their effort. Essentially, what this causes is very hyperactive bowel sounds above the obstruction. So if the obstruction is in the lower bowel, the left lower quadrant is going to be quiet, but more the right lower quadrant is going to have hyperactive bowel sounds. That's why we listen to all four quadrants. If you hear it very, very hyperactive and your right lower and your left lower is completely quiet, and the other thing that goes along with that is the patient becomes distended. Their abdomen becomes distended because that increased peristalsis on one side of the bowel that's trying to push, and then it's stuck on the other part of the bowel. It'll start becoming distended because it's not able to continue to move through. So that's typically what they look like. They start, and initially they'll have hyperactive bowel sounds, and then their abdomen will appear distended. If this continues on and the patient is not treated, they can actually become very, very sick. It can lead to a necrotic bowels. Like you can see how this one here, basically if this stays twisted like this, blood flow to the area is going to be decreased, and they'll end up with a necrotic bowel, which is a very serious situation. So basically, like if part of the bowel dies due to lack of oxygen to it, they'll have to remove that part of the bowel, and that, like I said, that can lead to a shock and a life-threatening situation. So bowel obstructions can typically be identified and treated early, and typically the patient will be have good results. However, if it's not identified and treated early enough, it could lead to a very serious situation. Basically, treatment is prevention. Make sure people are getting enough fluid. Make sure people are getting enough fiber in their diet to move things along. Identify those people at risk for constipation and make sure that they get the nutritional support that they need. The key features of small bowel and large bowel obstructions is identified in a table in your book. Make sure you look at that. It kind of compares and contrasts the small bowel obstructions versus large bowel obstructions. And it's typically abdominal discomfort and where that occurs. Sometimes in the small bowel you can see like visible peristaltic waves in the upper middle abdomen. And a lot of times what will happen above the obstruction is where the signs and symptoms will appear. So if it's lower, it's going to appear, more small bowel area. If it's small bowel, they might start to have upper epigastric abdominal distension, and they get nauseated very early. They start to vomit. So small bowels really, that patient's going to show more signs of nausea and vomiting as opposed to your large bowel obstruction, just because it's lower in the bowel. Nursing care of patients who have an intestinal obstruction, of course, we're going to monitor for fluid balance. We're going to monitor vital signs. Make sure you're checking that bowel, that abdomen for distension. Think about how we do that. They might order us to measure the girth of the abdomen to determine whether it's getting bigger. Monitor their eyes and nose. They may have an NG inserted, an NG tube. A lot of times we do that so that, especially if it's like a small bowel obstruction and everything's getting stuck above the small bowel, we might have to insert an NG in order to remove the content above that. Sometimes it's bile buildup, sometimes it's air, just to get out of there so the patient's more comfortable. Frequent mouth care. They're going to be MPO. We're not going to put anything in there because we know that it's not going to be able to move through. So we have to keep them in MPO. Make sure you understand the management of an NG tube. Checking it, make sure it's patent, all that good stuff. These patients may require surgery depending on the type of obstruction they have. Sometimes it means that we have to go in and remove a part of their bowel if it's twisted so much that we can't get it fixed. It's really the treatment as far as surgically is going to depend on the type of obstruction that it is. Postoperative care, though, is basically pain management, monitoring the NG, keeping them MPO until ordered otherwise to make sure that their belly has time to recover, and then also making sure we monitor their abdomen, making sure you monitor for bowel sounds and any further distension. This concludes the presentation for Part 2 of the lower GI disorders from Module 5 in Nursing 150. Here's a review question for you to just assess your learning. I encourage you to answer it, and the answers can be found in the comment section of your PowerPoint.